persistent trigeminal artery. Congenital hemangiomas has the same imaging appearance of infantile hemangiomas, but it differs in its life cycle. The proliferative phase has already finished by birth, so it's fully formed at birth. And according to its involutional pattern, it could be classified into rapidly involuting, partially involuting, or non-involuting congenital hemangiomas. Rapidly involuting congenital hemangiomas involute during the first year of life, in contrast to infantile hemangiomas, which involution doesn't typically begin until 6 to 12 months and requires several years. This is an example for congenital hemangioma. It's a one-day-old girl presented with right occipital scalp swelling. Ultrasound assessment shows echogenic soft tissue mass with internal arterial, low resistive, and venous vascularity, and an MRI T2 image shows hyper-intense soft tissue mass. This lesion regressed by 50% after 10 days and completely resolved by 22 months. Vascular malformations are, as we said, congenital errors of vessel morphogenesis. They typically present at birth and grow proportionate with the patient. While the lesions may grow occasionally rapidly at times of hormonal stimulation or when complicated by hemorrhage or infection, and they don't involute. Vascular malformations are categorized by primary constitutive channel type, either capillary, lymphatic, venous, or arteriovenous, and also subcategorized by relative flow velocity. Capillary malformations are cutaneous lesions diagnosed clinically as a port wine stain, and usually imaging is not required. However, imaging may be done in the setting of suspected associated findings as in Sturge-Weber syndrome. This is a 1-year-old girl with dark red patch over her left jaw. MRI assessment, coronal T2 image shows just ill-defined cutaneous and subcutaneous area of hyperintensity with ill-defined patchy enhancement post-contrast. This is an example for Sturge-Weber syndrome for this 5-month-old female child presented with port wine stain on the right side of the face. CT assessment shows right-sided hemiatrophy, cerebral hemiatrophy with gyral and subcortical calcifications. MRI assessment shows leptomeningeal enhancement and enlarged enhancing choroid plexus. This is another example of Sturge-Weber syndrome in 7-month-old boy with left facial capillary malformation, and MRI assessment also shows the leptomeningeal enhancement and the enlarged enhancing choroid plexus. Lymphatic malformation, 3/4 of lymphatic malformations occur in the head and neck, may be macrocystic, as Dr. Mu'taz said, or microcystic, or mixed. Macrocystic lesions appear as well-defined multicystic, multiloculated masses. However, microcystic have a more solid appearance. Ultrasound assessment shows the cystic structures with no detectable flow in color Doppler assessment except for the periphery or the intralesional septations. MRI assessment shows characteristic high T2 signal with just minimal peripheral enhancement, and due to intralesional hemorrhage, fluid leveling are seen and are considered a key for correct diagnosis. This is an example for macrocystic lymphatic malformation. Ultrasound assessment shows multicystic lesion with vascularity only detected in the septations and on the periphery of the lesion. MRI assessment, pre-contrast T1 image shows the multiloculated lesion with fluid leveling, and hyper-intense signal at T1 is initially due to hemorrhage. After contrast injection only shows peripheral enhancement. This is another example with multiple fluid leveling. This is example for microcystic lymphatic malformation at the floor of the mouth. It appears hyper-intense lesion as a multispatial. After contrast administration, there is no appreciable post-contrast enhancement. Venous malformations are spongy masses that are composed of abnormal veins lacking smooth muscle cells in their walls. They are typically soft, compressible, non-pulsatile, and may be associated with bluish skin discoloration. They are responsive to changes in venous flow, such as valsalva and sometimes compression of the ipsilateral jugular vein. On ultrasound, they appear as multiple tubules with no detectable or just a detected venous flow due to low velocities. Still, MRI is the mainstay for its evaluation. It shows marked hyper-intense signal at T2 weighted images, and after contrast injection, they show patchy enhancement with gradual bubbling or filling of contrast in the lesion over time. The most specific differentiating feature for venous malformation is the presence of phleboliths, and CT is the best for its diagnosis. Here is an example for multispatial venous malformation involving the floor of the mouth, sublingual, submandibular spaces, bilaterally, parapharyngeal, and retropharyngeal space, showing marked T2 hyperintense signal. Also could be noted multiple signal void foci, which are the phlebolith. And after contrast injection, there is patchy enhancement. Another example of multispatial venous malformation at the parapharyngeal, masticator, and buccal space, showing marked T2 hyperintense signal. This is another example at the masticator space, showing marked T2 hyperintense signal void phlebolith, and patchy post-contrast enhancement. And also intraorbital, I will find marked T2 hyperintense intraconal lesion that shows post-contrast enhancement, what's called cavernous hemangioma of the orbit. It's actually a venous malformation. Multifocal venous malformation are scattered throughout the body. If scattered throughout the body, blue rubber Pleb-Nevus syndrome should be considered, and these patients frequently have gastrointestinal bleeding due to mucosal lesions of the gut. As in this example, venous malformation at the base of the tongue appeared as T2 hyperintense lesion at MRI, and there's multiple venous malformations at the plantar surface of the feet. Lastly, high-flow vascular malformations, including arteriovenous malformations and the arteriovenous fistulas. These malformations lack the normal capillary bed between vessels. Malformation demonstrate a nidus of small vessels between the arteries and draining vein, whereas arteriovenous fistula is composed of direct macroscopic arteriovenous connection without intervening nidus. They may be congenital or secondary, and they present as skin deformity, warm pulsatile mass with a bruit or thrill, and may even presented by secondary manifestations or secondary symptoms such as arterial steal or high cardiac output failure. At imaging, when we see a tangle of malformed and enlarged dilated vessels, arteries, and veins, we suggest arteriovenous malformation. On Doppler ultrasound shows low resistant arterial waveform and arterialized venous waveform. CT and conventional angiography can show the detailed arterial and venous anatomy and can be helpful also for therapeutic embolization. MRI shows multiple numerous flow voids without associated soft tissue mass, and this could differentiate high flow lesions such as arteriovenous malformation from high flow vascular tumor such as hemangioma. That arteriovenous malformation are not associated with soft tissue mass. There may be perilesional T2 hyperintensity due to edema and venous congestion, but not actual MS. MR angiography will show the enlarged dilated feeding artery as well as the associated enlarged early enhancing draining veins due to shunting of blood. This is an example for arteriovenous vascular malformation. Sagittal T2 weighted image with fat suppression shows multiple enlarged flow voids at the lower lip, also seen as axial image with no associated soft tissue mass. Selective catheter angiography shows the enlarged, dilated in feeding artery as well as early enhancing abnormally filled dilated draining vein. This is an example for arteriovenous fistula at the left vertebral artery for this patient presented with a thrill along the left side of the neck. Post-contrast MRA shows the dilated tortuous proximal left vertebral artery with fistulous dilatation at the level of CV6, then the early enhancing dilated draining vein. Again, in the same case, selective catheter angiography shows the tortuous vertebral artery and the early enhancing dilated vein. Combined vascular malformation could be seen. The most common is veno-lymphatic malformation. This is an example of intraorbital veno-lymphatic malformation. At CT, there is intraorbital soft tissue lesion that shows multiple phlebolith, and at axial MRI image, there is multiple fluid leveling at T2 weighted image with enhancement at the post-contrast images. It was diagnostic for veno-lymphatic malformation. This is another example of multispatial lesion at the prevertebral spaces, shows T2 hyperintense signal with multiple fluid leveling and also multiple signal void foci of phlebolith that appeared at CT. To summarize, when we assess the clinical history of the lesion in a suspected vascular anomaly, if the lesion is not present at birth, appears at the first few weeks of life or even first few months, then rapid growth during the first year of life, then gradually involute over years, this is an infantile hemangioma, and if the lesion is fully formed and present at birth and without involution, it is a non-involuting congenital hemangioma. If it's fully formed, present at birth, and rapidly involute within the first year of life, it is a rapidly involuting congenital hemangioma. However, if the lesion is present at birth and grow proportionate with the patient, it is a vascular malformation. And for the important diagnostic imaging features, the prominent vessels, or in MRI, the flow voids, or at ultrasound, the arterial vessels could be seen in arteriovenous malformation and hemangioma. The enhancement pattern is it's cutaneous and subcutaneous at capillary malformation. No enhancement or only peripheral enhancement at lymphatic malformation. Patchy enhancement with gradual filling in, it's the venous malformation, and diffuse intense early enhancement seen in hemangioma. And fluid leveling is characteristic for lymphatic malformation. Soft tissue mass is seen with hemangioma, and however, in arteriovenous malformation, no associated soft tissue mass. Phlebolith is characteristic for venous malformation. And T2 signal, it could differentiate between venous malformation or veno-lymphatic malformations and hemangioma. It is marked T2 high signal at venous and lymphatic. However, it's intermediate at hemangioma. Usually, T1 signal is iso to hypointense in all lesions, but at lymphatic malformation may be high due to intralesional hemorrhage. This is a nice algorithm that is made or designed by our colleagues in Ain Shams University. Assess the vascular.
شكرا دكتورة حنان، متشكرين، شكرا جزيلا. نشكر الدكتورة حنان. الدكتورة حنان خطاب for your nice presentation. The last presentation will be also